Good evening. Am I audible? I hope I'm audible to you all. If I'm audible, can I see a confirmation from anyone who's on the live chat, please? So if you're joining the session for the first time, this is Dr. Shanmugapriya. I'm professor and head of the Department of Biochemistry at Government Thoothukudi Medical College. And I'm your Unacademy educator for biochemistry. And today's session, it's a rapid revision session for FMGE aspirants. And in this session, I will be discussing all high yield MCQs related to biochemistry. Okay. And before we start the session, let me tell you a few facts about Unacademy's plans. And because a price hike up to 20% is expected on all subscriptions by tonight 11:59 p.m., we strongly recommend that you use any of the educators code and avail 10% off. And you can use my code, which is my name, C. Shanmugapriya. And also to accelerate your NEET PG 2023 preparation, there is an offer wherein if you buy 6 months and above subscription, you get additionally 2 months subscription. And this is valid till tonight. And plus subscription gives you an access to both live and recorded sessions. It also gives you an access to a question bank with 25,000 plus clinical case-based MCQs. Iconic subscription gives you an access to both Unacademy and Prepladder platform. And if you have either a plus subscription or an iconic subscription, then you will be able to access all the structured courses which are happening here. So now we have a subject-wise batch for NEET PG 2023, which is starting tomorrow. And the duration of this batch would be 5 months. And all 19 subjects will be discussed in this, and I will be discussing biochemistry. And light subscription is something new, and this is all about practice tests. If you want access to practice tests and grant tests, then you can definitely use this. Hi, my friend. Good evening. So light subscription, we have currently 450 plus practice tests and 90 plus grant tests. You'll be able to access all these tests. And along with that, if you have light subscription or plus or iconic subscription, then you can access the NEET PG previous year question bank section. Hi, Dr. Villan. Hi, good evening, Dr. Shakir Khan. So you can also access the previous year question bank section. This section can be accessed through self-study practice section. And in this section, there are last 4-year question papers of NEET PG, INI, CET and FMGE. This section does not only include question. For every question, there is also a detailed explanation. So this will help you in the last lap preparation for any of your competitive and clearance exam. Good evening, Malay Joshi. And now what we do is after every plus class, every class that you attend as a subscriber, there is also practice paper. So giving this practice paper will help you understand your strengths and weaknesses. And if you think a particular part of the topic you are weak in, then you can get your doubts clarified directly with the educator. Good evening, Shivani. And we also have a batch for UPSC CMS revision and PYQs. And this batch covers medicine, surgery, OG, SPM and pediatrics. We have an MBBS Prof 1 course. This is for those who have just joined MBBS. In this course, anatomy, physiology, biochemistry, all 3 subjects will be discussed in an integrated manner. In the sense, it will be clinically integrated and all 3 subjects will be aligned. And guidance will also be given regarding practicals and viva. So if you have any of your friends or juniors who have just joined MBBS who's looking for a guidance, you can definitely recommend this. Hi, Lakshmi Subramanian. And this is the free test calendar for this month. Try to attend as many free tests as possible. And to enroll for any of these free tests, if you need a code, you can use my code, C. Shanmugapriya. And this is the current NEET PG subscription plan, wherein if you want plus subscription, minimum is 3 months, that would cost you 11,250. Iconic subscription, minimum is 6 months, that would cost you 36,000. Light subscription, minimum is 1 month, that would cost you 1,125. And MBBS Prof 1 course, 3 months would cost you 4,950. UPSC 1 month is 2,475. And all this cost would be inclusive of 10% discount. Okay. So that's all about Unacademy's plans. Let's now start discussing few previous year questions. So to revise, I've chosen few previous year questions based on frequently asked topics. Okay. So this is the first question for today evening. Yes, this is for FMG Amit. A person has a history of alcoholism. This is a previous year question, FMGE question. Has a history of alcoholism for 20 years. He avoids alcohol for 2 days. So alcohol withdrawal. And presents with agitation. Sumit says it's A. Usha Yadav thinks it's B. My friend thinks it's C. Okay. So nobody to choose D. In which case everything will be covered. Anybody to choose D? Usha says B for sure. Shakir Khan. Everybody says B. Okay. So what are the presentation? I will help you understand this. So what are the findings here? Yeah, the findings are global confusion, disorientation, hallucination, fever, high blood pressure, diaphoresis, autonomic hyperactivity. The most common causes. So straight away, I'm going to exclude choice D, Goa. Usha thinks it's a part of Goa. Medico thinks it's A. Good. So I'm happy that there are some of you who have chosen it as A. Amit has chosen it as A. So the answer for this question is delirium tremens. Yeah, why am I choosing it as delirium tremens? I will tell you now. So first I'm excluding pancreatitis because pancreatitis has got nothing to do with autonomic hyperactivity. It has got nothing to do with hallucination. Okay. Now can it be Wernicke's or Korsakoff? So both Wernicke's and Korsakoff, listen to this, both are manifestations of thiamine deficiency, B1 deficiency. And a chronic alcoholic is prone to develop thiamine deficiency for multiple reasons. One is an alcoholic often skips meals. Alcohol provides, it's a source of empty calorie. It provides high energy, no micronutrient at all. So chronic alcoholic is susceptible to develop all micronutrient deficiencies. But of all those micronutrient deficiencies, which deficiency is very common in an alcoholic? It is thiamine deficiency, which is very common because alcohol interferes with thiamine absorption. In which case, acute thiamine deficiency will present as Wernicke's encephalopathy. I am going to tell you that, Vinod. I will now tell you the difference between Wernicke's and Korsakoff. So, acute thiamine deficiency will present as Wernicke's encephalopathy. Chronic thiamine deficiency will present as Korsakoff. K, chronic. Korsakoff is chronic thiamine deficiency. Now, Wernicke's encephalopathy will present as GOA. What is GOA? As Usha had mentioned it, Wernicke's, Korsakoff, same psychosis is complication. I'm going to tell you that. So Wernicke, what will be the manifestation? GOA. What does GOA stand for? Global confusion, ophthalmoplegia and ataxia. Do you understand this? Global confusion, ophthalmoplegia, ataxia. So based on two reasons, you might think it is Wernicke's encephalopathy. Reason number one is the person is an alcoholic. Reason number two is there is global confusion. But in Wernicke's encephalopathy, you don't find any physical manifestations. You will not find tremors. You will not find the autonomic hyperactivity. No increase in blood pressure. Do you understand this? That is why I am excluding Wernicke's encephalopathy. Can it be Korsakoff syndrome or chronic thiamine deficiency? Chronic thiamine deficiency will present as memory loss. So what is the difference between Wernicke's and Korsakoff? In Wernicke, there is not a complete memory loss. They are just confused. Whereas in chronic, there is completely memory loss, amnesia, retrograde amnesia, anterograde amnesia. And because there is amnesia, to fill up the gap, they start fabricating stories. Unconsciously, they start building up stories, which is called as confabulation. So have you heard of honest lies? Very good, Usha. Have you heard of honest lies? For example, a woman who is a chronic alcoholic with chronic thiamine deficiency will start saying, this is not my child, this is my sister's child. Yeah, she might look at her own daughter or son and would say that, not because she's getting rid of the responsibility, but because she has forgotten the fact that she has given birth to the child. And to fill up that memory gap, she would say, this is my sister's child. So that's called as honest lying or confabulation. Again, in both Wernicke's encephalopathy and in Korsakoff syndrome, you are not going to find autonomic hyperactivity or increase in blood pressure. So what are you left with? All of you, can you tell me the answer now? Because you have excluded choice B, choice C and choice D. As Amit has mentioned, and Amit and Medico, both of them have mentioned it. What is answer? It is delirium tremens. So what is delirium tremens? It's one of the manifestations of alcohol withdrawal. Yeah, it is a manifestation of alcohol withdrawal and most commonly presents on the second day. Between 2 and the 10th day, between 2nd and the 10th day of alcohol withdrawal, the person might present with delirium tremens. And what are the manifestations? Remember, it is GHN. Yeah, GH nurse, government hospital nurse, GHN. So what does GHN stand for? G stands for global confusion again. H stands for hallucination. N stands for nightmares. So tell me, what are the features of delirium tremens? Delirium tremens will present with global confusion, hallucination and nightmares. Along with that, also anticipate physical features. What are the physical features? Increase in blood pressure, increase in heart rate, increase in body temperature. Yeah, so and tremors, that is why delirium tremens. So along with all these manifestations, if you find physical manifestations like increase in body temperature, blood pressure, heart rate and tremors, then it is delirium tremens. Clear? I am happy my friend has understood it. So what is answer? The answer is choice A. Okay. And this is again a previous year question. I am very sure you all have come across this question. Yeah. So 2-month-old boy presented with ambiguous genitalia. His blood pressure was normal. Dihydroxytestosterone level was low. The probable diagnosis is. Can you try to answer this question? Anybody? Is it 21 beta hydroxylase or 11 beta hydroxylase? Sumit says it's A. Dr. Villan, what is your doubt? First symptom for delirium tremens. I don't know the sequence in which the symptom appears, but I know for sure confusion is a component. Probably that's the first symptom, but I'm not very sure. Maybe I will post that in the Telegram group. So Vinod Raj says it's choice A. Shrikant says it's choice B. Manimoli says it's choice C. Many of you have answered it as choice C, and the answer is choice C. Okay, but when this question was asked in FMGE paper, most of the students had chosen it as 21 beta hydroxylase deficiency because that's the most common type of congenital adrenal hyperplasias. So all these are congenital adrenal hyperplasias and the most common cause would be 21 beta hydroxylase deficiency. But in this case, choice A is not the right answer because do you see that they have mentioned that the blood pressure is normal? Yeah, blood pressure is normal, but 21 beta hydroxylase deficiency will present as salt wasting form. What do you mean by salt wasting form? The person will lose all sodium. So what will they present with? They will present with hyponatremia and hypotension. So had it been low blood pressure, then you choosing it as 21 beta hydroxylase is accepted. But because it says blood pressure was normal, it is not 21 beta hydroxylase deficiency. If you're asking me how do I remember it in exam, 21, yeah, only when 2 gets wasted, it is 1, right? 2 minus 1 is 1. So 21 beta hydroxylase is a salt wasting form. And another congenital adrenal hyperplasia, which is also a salt wasting form, is 3 beta hydroxysteroid dehydrogenase deficiency. So tell me, what are the 2 congenital adrenal hyperplasias? All of you please memorize it because you're in the last lap of preparation. You should start memorizing it real time. Whenever you're listening to a session, please memorize it. So there are 2 congenital adrenal hyperplasias which present as salt wasting forms. One is 21 beta hydroxylase deficiency. The other one is 2 plus 1 is 3. 3 beta hydroxysteroid dehydrogenase deficiency. So these are salt wasting forms. What are the hypertensive forms? The other 2 will be hypertensive forms. So 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency are hypertensive forms. Okay. And the next fact that I want you all to remember is all congenital adrenal hyperplasias will present as female pseudohermaphroditism. What do you mean by female pseudohermaphroditism? A female child showing hirsutism. Yeah, female child showing hirsutism is female pseudohermaphroditism. But what is provided here? I will share the PDF in my Telegram group, Sumit. But what is provided here? The history says it's a boy who is presenting with ambiguous genitalia. So it is male pseudohermaphroditism. So tell me which condition will present as male pseudohermaphroditism. It is 17-alpha hydroxylase deficiency. That is the only disorder which presents as male pseudohermaphroditism. So I am going to summarize all about congenital adrenal hyperplasia. All of you please listen to this. Also try answering these questions in the chat box, please. Can you tell me which is the most common congenital adrenal hyperplasia? Anybody? The most common congenital adrenal hyperplasia. Can I see the answer in the chat box? The most common congenital adrenal hyperplasia is 21 beta hydroxylase deficiency. And what will it present as? 2 when it gets wasted becomes 1. So it presents as salt wasting form. So what are the congenital adrenal very good, Malay. So what are the congenital adrenal hyperplasias which present as salt wasting forms? 21 beta hydroxylase deficiency and 3 beta hydroxysteroid dehydrogenase deficiency. What are the hypertensive forms? Hypertensive forms will be 11 beta hydroxylase and 17 alpha hydroxylase. And all these congenital adrenal hyperplasias will present as female pseudohermaphroditism. The only one which presents as male pseudohermaphroditism is 17 alpha hydroxylase defect. Clear? So look at the question here. It's a male pseudohermaphroditism. It's a case of male pseudohermaphroditism without salt wasting. The moment you see that the blood pressure is normal, you're going to exclude 21 and 11. No, 21 and 3 beta hydroxysteroid dehydrogenase deficiency. And then because it is male pseudohermaphroditism, you're excluding this. So what is the right answer? The right answer is 17 alpha hydroxylase. And this is also a previous year question, so I have not framed any of these questions all by myself. I have chosen all these questions to explain you a fact that FMGE question paper is not very simple. Yeah, you cannot get away by just learning facts. Just because it's an FMGE clearance exam, you cannot say, okay, it's FMGE, I'll just learn facts. So it's equally difficult as NEET PG. So please get into the conceptual learning mode. So what is the answer? Very good, Dr. Villan. Very good, Medico. The answer is the drug of choice in mountain sickness is acetazolamide. Okay, so why should you give acetazolamide in mountain sickness? Because acetazolamide, very good, Kaustubh. Very good, Usha. Because acetazolamide acts by inhibiting what? It acts by inhibiting carbonic anhydrase in the proximal convoluted tubule. Yeah, it acts by inhibiting carbonic anhydrase in the proximal convoluted tubule. So how does it help in mountain sickness? What is the basic pathology behind mountain sickness? Can anybody tell me? Why are you worried about getting exposed? Very good. Excellent. All of you have answered it right. So why are you worried about mountain sickness or getting exposed to hypoxia quickly? Yeah, if you get exposed to hypoxia, the major defect in mountain sickness is you're getting exposed to low partial pressure of oxygen, in which case the person will hyperventilate. What will happen when the person hyperventilates? The person washes away carbon dioxide, so that causes alkalosis. So the acid-base abnormality that you expect in mountain sickness is respiratory alkalosis. When there is respiratory alkalosis, respiratory center will get depressed, because one of the mechanisms by which your chemoreceptors get stimulated is acid. Only when there is an increase in hydrogen ion concentration in the CSF, your chemoreceptors will get stimulated. But when you hyperventilate, when there is respiratory alkalosis, central chemoreceptors do not get stimulated. So respiratory center is depressed. That is why we are worried about climbing uphill quickly. So the major defect that you observe here is alkalosis. So you should give a drug which causes acidosis. Which drug causes acidosis? Acetazolamide causes acidosis. How does it cause acidosis? Because acetazolamide inhibits carbonic anhydrase in the proximal convoluted tubule. Thereby what is not reclaimed into the circulation. Yeah, thereby what is not reclaimed into circulation? Bicarbonate is not reclaimed into circulation. So there is a decrease in the buffer. When buffer concentration decreases, acid concentration increases. And this acid will keep the chemoreceptor stimulated. That will stimulate the respiratory center. And that is why what is the drug of choice, all of you? What is the drug of choice in mountain sickness? It is acetazolamide. So don't just memorize it. Try to understand why acetazolamide is used in mountain sickness, because acetazolamide induces acidosis. And this acidosis stimulates the respiratory center. So you will not develop alkalosis. You will not experience respiratory depression when you climb uphill. Okay. And this is again a frequently asked topic. How many of you have come across this question on oxyhemoglobin dissociation curve? If you have come across it, can I see a thumbs up please? Which of the following shifts the given curve to the left? Can anybody answer this question? Which causes the shift of the curve to the left? It is decrease in body temperature. Very good. Good, Usha. Hypoxia shifts the curve to the right. Yes, good. So oxyhemoglobin dissociation curve, I'm going to tell you few facts which you should remember. Okay. So how is oxyhemoglobin dissociation curve drawn? This curve is drawn with what along y-axis? Along y-axis it is percentage saturation. Y and percentage look alike. Yes or no? Y and percentage look alike. So along y-axis it is percentage saturation. Along x-axis it is partial pressure of oxygen. And in such a graph we are worried about whether the curve gets shifted to the right or the curve gets shifted to the left. Because shift of the curve to the right or shift of the curve to the left will tell you about P50. Can anybody tell me what is P50? P50 is the partial pressure of oxygen at which it is 50% saturated. Can you see that here? What is P50? P50 is the partial pressure of oxygen at which it is 50% saturated. So what do I mean when the curve gets shifted to the right? Suppose I say the curve is placed here. Yes, 28 very good Usha, 28 millimeter of mercury for hemoglobin. So suppose I say the curve gets shifted to the right. It means what is happening to P50? Yeah, it means P50 is increased. Do you understand this? If I say the curve gets shifted to the right, I mean to say P50 has increased. So what do I mean when I say P50 is increased? What do I mean when I say P50 is decreased? When I say P50 is decreased, I mean to say even at such a low partial pressure of oxygen, it is 50% saturated. Do you understand this? Whenever I say P50 is low, I mean to say even at such a low partial pressure of oxygen, it is 50% saturated, which means its affinity is high. So P50 and affinity are inversely proportional. Do you all understand this? P50 and affinity are inversely proportional. So when I say the curve gets shifted to the right, I mean to say P50 is high or affinity is low. So when will you want the affinity of hemoglobin for oxygen to be low? Tell me the answer. When will you want the affinity of hemoglobin for oxygen to be low? Whenever you want effective deoxygenation to happen to the tissues. When will you want effective deoxygenation to happen to the tissues? Whenever there is hypoxia. Isn't that right? Whenever there is hypoxia, whatever oxygen is available should be given off to tissues. How can you give all oxygen to tissues? By reducing the affinity of hemoglobin for oxygen. Anemia. Why in anemia the curve should get shifted to the right? Yeah, why will you want the anemia to shift the curve to the right? Because anemia is oxygen carrying capacity of hemoglobin being low. Even if the carrying capacity of hemoglobin is low, whatever is being carried should be given off to the tissues. How can you do that? By reducing the affinity, by shifting the curve to the right. And whenever there is increase in body temperature, listen to this, whenever there is increase in body temperature, the curve should get shifted to the right. Because increase in body temperature means there is an increase in the rate of local metabolism. And whenever there is an increase in the rate of metabolism, you should provide more oxygen to tissues. Only then metabolism can be supported. So how can you give more oxygen to tissues? By reducing the affinity, by shifting the curve to the right. And in acidosis, your aim is to avoid further acid production. Isn't that right? All of you, can you answer that? Yes, increase in demand. Very good. So in acidosis, your aim is to inhibit further acid production. To inhibit further acid production, you should suppress anaerobic metabolism and you should support aerobic metabolism. How can you support aerobic metabolism? By giving more oxygen. How can you give more oxygen? By reducing the affinity. Is that clear? So now tell me, when will you want the curve to get shifted to the right? You will shift the curve to the right whenever P50 has to be high, or whenever the affinity has to be low, or whenever you want effective deoxygenation to happen to the tissues. Example will be hypoxia, anemia, increase in body temperature and acidosis. So if increase in body temperature and acidosis shift the curve to the right, what will happen in decrease in body temperature? Decrease in body temperature and alkalosis. Decrease in body temperature and alkalosis will shift the curve to the left. Clear? So that's about oxyhemoglobin dissociation curve. I am happy that all of you are interacting. So answer this, which of the following shifts the curve to the left? Decrease in body temperature will shift the curve to the left. Another condition which shifts the curve to the left is alkalosis. Okay. So did you see this question? Fat sugar baby is seen in. It was a very simple question which was asked recently. Fat sugar baby is seen in. Can you tell me the answer? Is it Koshakar, Marasmus, diabetes or hypothyroidism? It is very good, Shakir. It is Koshakar. Yes. So fat sugar baby is seen in Koshakar. So tell me, what is the difference between Koshakar and Marasmus? Marasmus is complete calorie deficiency. Yeah, which means a child does not take food at all. In the sense, a child is not provided with any food, no diet. So no diet, no calorie. Completely calorie deficiency. Whereas Koshakar, calorie is maintained, but the source of the food which provides the calorie is predominantly of carbohydrate and fat. Do you understand this? So what happens in Koshakar? Yes, edema, you're right. So in Koshakar, there is no calorie deficiency. The calorie that is required is met. But the quality of the food which provides a calorie is not good. In the sense, the food has got predominantly carbohydrates and fats. And that is why those children are called as fat sugar baby. Which means food is rich in fat and carbohydrates. So what is deficient? What is deficient? Protein is deficient. When protein is deficient, there will be hypoalbuminemia. And this hypoalbuminemia will cause edema. So pitting edema is a feature of Koshakar because there is protein malnutrition. Protein energy malnutrition. And not only pitting edema, subcutaneous fat is maintained in the case of Koshakar. Whereas in Marasmus, complete absence of subcutaneous fat. Imagine a child who has completely lost all subcutaneous fat. Yeah, that is Marasmus. In Koshakar, subcutaneous fat is maintained. And in Koshakar, you actually will observe fatty liver. Yeah. In Koshakar, there is fatty liver and abdominal distension. And the child will be apathetic. In the sense, depressed. A dull child. Imagine a dull child with an abdominal distension with pitting edema with subcutaneous fat. That is Koshakar. Whereas Marasmus is the child will be irritable, crying. Okay, so here it is apathetic. And what about hunger? No hunger at all in Koshakar. Whereas Marasmic children, they will be hungry. So these are the differences between marasmus and kwashiorkor. So if you understand the basic difference, the other differences will come automatically. So what is the basic difference? In kwashiorkor, calories provided, required calories provided. Marasmus, the required calorie is not provided. In kwashiorkor, the required calories provided only by carbohydrates and by fat. So what is deficient? Protein is deficient. If protein is deficient, there will be hypoalbuminemia causing pitting edema. And not only pitting edema, subcutaneous fat is maintained. There is actually fatty liver with abdominal distension, and the child is apathetic, a dull child. Whereas marasmic children will be irritable and crying. Kwashiorkor children, they don't feel hungry. Marasmic children will be hungry. Okay? Yes, emaciation, yes. The micronutrient that is deficient following post-ileal resection. Following post-ileal resection, which micronutrient will be deficient? It is B12. Why is it B12? Because the only micronutrient that gets absorbed in the terminal ileum. Very good, Malay. Very good, Dr. Villan. Very good, Vinod. Raj, Bornian, Anonymous. Excellent. All of you have answered it right. Yeah, it is B12 because in terminal ileum, the only micronutrient that gets absorbed in terminal ileum is B12, and the other one which gets absorbed in terminal ileum is bile salt. Yeah, bile salt and B12 get absorbed in the terminal ileum, and it is because only when B12 binds to cobalamin receptors in terminal ileum they get absorbed. Okay, so it is, answer is B12. Yes, macrocytic anemia. So this is what you answered, right? Usha Yadav, a vegetarian patient presents with anemia and hypersegmented neutrophils. So all FMGE aspirants, the day before your exam, please go through vitamins. Okay, FMGE is known for asking you questions about B12, folate, homocysteine, B6. So vitamin is a favorite topic of every FMGE exam. So the day before exam, please revise vitamins. Okay. Okay, so vegetarian patient presents with anemia and hypersegmented neutrophil, the most probable causes. Very good. Megaloblastic anemia. If you're a class 11 student, I don't think you'll be able to understand this. Okay, so I think you can optimally utilize your time by watching some other video, Bornian. So it is megaloblastic anemia. So why am I saying it is megaloblastic anemia? For two reasons. One is vegetarian. You know, B12, most of the dietary sources of B12 will be non-vegetarian. So vegans, yeah, vegan who are completely on vegetarian diet, they're more prone for B12 deficiency. And along with that, what is observed? Anemia and hypersegmented neutrophils. What do you mean by hypersegmented neutrophils? If you see neutrophils in which there are more than 6 lobes, 6 or more lobes are present in nuclei. Yeah, if you see 6 or more lobes present in neutrophil, then those are called as hypersegmented neutrophils. So anemia, hypersegmented neutrophils, then that is B12 deficiency. Yeah, 6 or more lobes, or if 3% or more of neutrophils have 5 or more lobes. Do you understand this? Even if you see one neutrophil with 6 lobes, or if 3% of neutrophils have 5 or more lobes, then both are called as hypersegmented neutrophils. Okay, so it is megaloblastic anemia. So if you're asking me why should B12 deficiency present with hypersegmented neutrophil, it is because B12 deficiency will cause folate deficiency. Yeah, please understand this. I will tell you why later on. But for now, whenever there is B12 deficiency, there is methylfolate trap. What do you mean by methylfolate trap? Indirectly, it causes folate deficiency. And without folate, what cannot be synthesized? Purines and pyrimidines cannot be synthesized, because tetrahydrofolate is necessary for purine and pyrimidine synthesis. Without purines and pyrimidines, very good my friend, without purines and pyrimidines, what will not happen? Replication cannot happen. Without replication, nucleus cannot divide. Do you understand this? Without replication, nucleus cannot divide. So what kind of cells will you see? You will see very large cell with huge cytoplasm, with excess cytoplasm, with hypersegmented nuclei, which are ready to divide but they are not able to divide. Do you understand this? Cells have grown but they are not able to divide. That is why what will you see? You will see macrocytic anemia. Is that clear? Yeah, nucleocytoplasmic disproportion. So tell me, what is the sequence? In B12 deficiency, indirectly there is folate deficiency. Without tetrahydrofolate, purines and pyrimidines cannot be synthesized. Without purines and pyrimidines, replication is not possible. Without replication, nucleus cannot divide, and that causes nucleocytoplasmic disproportion of macrocytic anemia or megaloblastic anemia. A person presents with diarrhea, dermatitis and dementia. What is the probable cause? I think it's the simplest question ever. Tell me the answer. Diarrhea, dermatitis and dementia. What is the probable cause? More lobes because nucleus has not divided, Usha. Nucleus has grown but is not able to divide. Very good, all of you. I'm happy that all of you are answering it right. So diarrhea, dermatitis and dementia, 3 Ds, right? 3 Ds of pellagra. 3 Ds of pellagra caused by niacin deficiency. So what is answer? The answer is pellagra. What will you find in cystinuria? Can anyone answer? Death if untreated. I am strongly against including death as one of the features of pellagra because we are doctors. We are not supposed to allow it to happen. Yeah, that too in this era. Yeah, what will you find in cystinuria? Cystinuria, you will find recurrent renal stones. Very good, my friend. So cystinuria will present as recurrent renal stones. It will present as obstructive uropathy. And what kind of renal stone will you see? Cis sounds like 6, right? Cis sounds like 6. So hexagonal crystals. Yeah, if you see hexagonal crystals in renal stones, that is cystinuria. Okay, that is cystinuria, wherein as my friend has answered it, 4 amino acids. The mnemonic for those 4 amino acids will be COLA. What does COLA stand for? Cysteine, ornithine, lysine and arginine. Yeah, cysteine, ornithine, lysine and arginine are the 4 amino acids which get reabsorbed in the proximal convoluted tubule through a common transporter. Okay, all these 4 amino acids get absorbed along the proximal convoluted tubule through one common transporter. So when that transporter is defective, all these amino acids will be found in urine. There is excess cysteine, excess ornithine, excess lysine and excess arginine. So excess cysteine will form cystine stones. Cysteine will get deposited here as cystine stones. And those stones are hexagonal crystals. Okay, so that's about cystinuria. Yes. And what will you find in alkaptonuria? Alkaptonuria is black urine disease. Alkapton means black. Alkaptonuria is black urine disease. So if the history says urine turns dark on standing, all of you listen to this, urine turns dark on standing, then what is your diagnosis? Your diagnosis is alkaptonuria. And porphyria, you know, they will present with neuropsychiatric manifestations and photosensitivity, right? What will be the presentation of porphyria? They present with neuropsychiatric manifestations and photosensitivity. So what is the right answer here? Very good, homogentisic acid, yes. So what is the next answer? Tell me the answer for this question. Menkes, there is another question on alkaptonuria. I will explain that. Yeah, oochronosis. I will be telling about all that in the next question. We have a question separately on alkaptonuria. Try to answer the question that is projected here. Menkes disease is caused by, very good, copper deficiency. Copper toxicity causes which disease? Copper toxicity causes Wilson's disease. One of you have answered it as Manimoli has answered it as C. Zinc deficiency does not cause Menkes disease. One of the causes of zinc deficiency is Acro Dermatitis. Yeah, what is it? It's Acro Dermatitis entropathica. What do you mean by Acro Dermatitis entropathica? It is an autosomal recessive condition wherein there is defective absorption of zinc along the enterocyte. And that zinc deficiency will cause dermatitis in the periphery. and that is why it is Acro Dermatitis enteropathica. So this is Menkes is not zinc deficiency, Menkes is copper deficiency. Excellent. Okay, so few facts about Menkes disease. Menkes disease is caused by the defect of a gene. Which gene? ATP7A. Yeah, Menkes disease caused by the defect of the gene ATP7A, and the role of this protein, function of this protein is to cause copper absorption along the intestine as well as to incorporate copper into enzymes. Do you understand this? ATP7A gene codes for a protein which is related to copper absorption and copper incorporation into enzymes. So when copper is not absorbed along the intestine, that will cause copper deficiency. When copper is not getting incorporated into enzymes, enzymes like lysyl oxidase will be defective. So what will it cause? One is copper deficiency, the other one is lysyl oxidase, and ceruloplasmin will be defective. And when lysyl oxidase is defective, collagen cannot be synthesized. Yeah, properly cross-linked collagen cannot be synthesized. So hair will not have a proper texture. You know, the texture of hair is because of collagen, right? So when collagen cross-linkages are missing, that causes kinky hair. And collagen gives strength to the bones. And that is why Menkes disease patients present with repeated bone fractures. And they present with hypotonia. So tell me, what are the features of Menkes disease? Because lysyl oxidase, which is necessary for collagen cross-linkage formation, is defective in this condition. There is kinky hair, there are multiple fractures and hypotonia. Okay. So tell me, Menkes disease is caused by what? Copper deficiency. Vitamin C is, yes, it's required for collagen. That is not the reason for kinking hair, my friend. Do you understand that? Good evening, Abhinandani. How are you? Do you understand that? Yeah, here the reason for kinking hair is lysyl oxidase is defective. Cholesterol is synthesized from what? Cholesterol is synthesized from, very good Tavish, very good Manimuli. All of you good. Anonymous, excellent. So answer is, it is synthesized from acetyl-CoA. So all of you listen to this. Acetyl-CoA has got multiple fates. I mean, good to know that you're good, Abhinandani. So acetyl-CoA has got many fates. One is acetyl-CoA can get into citric acid cycle. Yeah, it can get into citric acid cycle, in which case it will come out as carbon dioxide. Or if acetyl-CoA cannot get into citric acid cycle, acetyl-CoA condenses to form ketone bodies. Yeah, it condenses to form ketone bodies. Otherwise, acetyl-CoA can be used for anabolism, where it is a building block of both fatty acid and cholesterol. Acetyl-CoA is a building block of both fatty acid and cholesterol. So tell me, what are the fates of acetyl-CoA? Acetyl-CoA gets into citric acid cycle, comes out as carbon dioxide, or acetyl-CoA condenses to form ketone bodies. Acetyl-CoA is a building block of fatty acid and cholesterol. Okay. From cholesterol you get bile acids. Do you understand the difference? Acetyl-CoA forms cholesterol. From cholesterol you synthesize bile acids. What happens after a meal? This is also a previous FMGE question. Can anybody answer this? After a meal, is there an increase in insulin or is there an increase in glucagon? No change in both. Decrease in insulin and glucagon. What is your right answer? After a meal, what happens to blood glucose level? Yeah, I will be covering most of the FMGE topics, Pandit. Yes, that's my aim. That's why it is a long session. It will be an 1.5 hour session, 90-minute session. Yes, answer is choice A. So following a meal, what happens to blood glucose? Blood glucose increases. When blood glucose increases, to cause glucose uptake into cells, insulin will be released from pancreatic beta cells. And whenever insulin is released from pancreatic beta cells, it gets released along with GABA. And that GABA suppresses glucagon secretion. So after a meal, what happens? There is increase in insulin and decrease in glucagon. Okay, just to reduce the blood glucose level or to allow tissues to use the blood glucose. Which of the following activities are low in riboflavin deficiency? This is also a previous FMGE question and this was asked recently in NEET PG. Riboflavin deficiency. So the clue that I always give for all my students is ribbon and glue go hand in hand. Have I told you? Yeah, ribbon and glue go hand in hand. So riboflavin deficiency, it is glue glutathione reductase enzyme activity. Okay, so whenever you suspect riboflavin deficiency, which enzyme activity will be low? It is glutathione reductase activity. So don't get confused between glutathione reductase and glutathione peroxidase. Riboflavin is not necessary for glutathione peroxidase. Is that clear? It is glutathione reductase. What is necessary for glutathione peroxidase? Selenium. Yeah, selenium is necessary for glutathione peroxidase. What are the other enzymes which are dependent on selenium? Selenium is necessary for glutathione peroxidase, thioredoxin reductase. Yeah, thioredoxin reductase and 5'-deiodinase. Can you memorize it? Yeah, selenium is necessary for the activity of glutathione peroxidase, thioredoxin reductase and 5'-deiodinase. For riboflavin, it is glutathione reductase. And transketolase. When will you estimate transketolase activity? B1. When you suspect thiamine deficiency. Yeah, when you suspect thiamine deficiency, you should estimate transketolase activity. Okay. Glycogen phosphorylase. Excellent, Usha. I am happy that you remember all of that. Yes, thiamine is necessary as a coenzyme for PDH, alpha ketoglutarate dehydrogenase, branch chain keto acid dehydrogenase and transketolase. But for remembrance, thiamine deficiency, if you suspect thiamine deficiency, you estimate transketolase activity. And glycogen phosphorylase is B6. Pyridoxal phosphate. Pyridoxal phosphate is present as a coenzyme in glycogen phosphorylase. How about propionyl-CoA carboxylase? All carboxylases need biotin. Please memorize it. All carboxylases need biotin. So have you memorized all these facts? Yeah, can we summarize it? Yeah, let me summarize it. To summarize it, thiamine deficiency. If you suspect thiamine deficiency, what will you estimate? I want all of you to be active in the chat box, please. If you suspect thiamine deficiency, what will you estimate? You will estimate transketolase activity. Okay. If you suspect riboflavin deficiency or B2 deficiency, ribbon and glue. So what will you estimate? Glutathione reductase activity. Okay, and then B6 is present in what? B6 is present in glycogen phosphorylase. Biotin is necessary for carboxylases. Biotin is necessary for carboxylases. So, which of the following enzymes is defective in von Gierke's disease? Tell me the right answer. Is it choice A or choice B or C or D? Tell me which choice it is. A, B, C, D. I don't want any short forms because all these short forms represent GP. Right? So don't write any short forms. Tell me A, B, C, D. Which is the right answer? Very good. Excellent. Yes. It is choice D. Von Gierke's disease is caused by a defect of glucose 6-phosphatase. So can we quickly recall about all glycogen storage disorders? Yes, profound hypoglycemia. Very good, Usha. So we'll discuss about 7 glycogen storage disorders, the name and the enzyme defect. Yeah. So quickly tell me. Type 1. 1 is von. Yeah. 1 is von. Von Gierke's disease. You don't have to write anything. I will provide the PDF. Now listen and memorize. Okay. So von Gierke's disease, the enzyme which is defective is glucose 6-phosphatase. Good. Yes. Doll-like faces. Yes. So glucose 6-phosphatase defect causes type 1 of von Gierke's. Type 2 is Pompey's. Yeah, type 2 is Pompey's disease, wherein the enzyme which is defective is acid maltase. Please memorize it. It is acid maltase or alpha glucosidase. Acid maltase or alpha glucosidase defect causes Pompey's. At this point, also memorize that beta glucosidase defect causes what? Beta glucosidase defect causes Gaucher's disease. Okay, beta glucosidase defect is Gaucher's, alpha glucosidase defect is Pompey's. Okay, and then type 3. Tell me which is the third alphabet. Third alphabet is C. Okay, what does C stand for? Cory's disease. Type 3 is Cory's disease. After C, the alphabet is D. What does D stand for? D-branching enzyme. Okay, D stands for D-branching enzyme. And type 4 is AB. Very good. Type 4 is AB. What does A stand for? Anderson. A stands for Anderson. And the enzyme which is defective is branching enzyme. So type 3 is Cory's D-branching enzyme. C followed by D, D-branching enzyme. Type 4 is Anderson, A followed by B. It is branching enzyme defect. Okay. Type 5 is, what is type 5, all of you? Type 5 is McArdle's. M for M. McArdle's is caused by the defect of muscle phosphorylase. M for M. McArdle's is caused by the defect of muscle phosphorylase. And then type 6 is Hers. Yeah, type 6 is Hers. H for H. Hepatic phosphorylase. Hers is hepatic phosphorylase defect. And type 7 is, already somebody gave the right answer. Type 7 is Tarrow's disease. Tarrow's disease, the enzyme which is defective is phosphofructokinase 1. Yeah, Tarrow's disease, the enzyme that is defective is phosphofructokinase 1. So are you clear about these names? Yeah, step number 1 for you to learn about all glycogen storage disorders is to know the name and the enzyme defect. Okay, so can you quickly tell me type 1? What is type 1? 1 is von Gierke's. Type 2, Pompey's acid maltase defect. Type 3, Cory's D-branching enzyme defect. Type 4, Anderson branching enzyme defect. Type 5, McArdle's muscle phosphorylase defect. Type 6, Hers hepatic phosphorylase defect. Type 7 is Tarrow's or phosphofructokinase 1 deficiency. Okay. So this was asked in June 2020. Okay. Now look at the next question which was asked in June 2021. Just the next year. The next year they have stopped asking you. I won't say they've stopped, but they've started asking you clinical case based MCQs. Yeah, just in 1 year do you see the transition? Now the question is, an 8-month-old infant presents with hypoglycemia. On examination, hepatomegaly was observed. Blood investigation revealed lactic acidosis, ketosis and xanthomas. Very good. I am happy that all of you are choosing the right answer. Xanthomas on the buttocks. What is the most probable enzyme deficiency? Yes. Answer is glucose 6-phosphatase deficiency. For those of you who want to know why is it glucose 6-phosphatase deficiency, let me exclude all other choices. What is the principal presenting feature? Because when we say repeat, please don't expect the same history to be given. The history will be twisted. So even when it is twisted, you should be able to answer the question. So you should know how do we arrive at this diagnosis. Okay, so what is the principal presenting feature here? The principal presenting feature here is hypoglycemia. Do you think choice A will cause hypoglycemia? Branching enzyme defect. Branching enzyme is an enzyme that is involved in glycogen synthesis. When will you find hypoglycemia? There are only 2 pathways in your body which can maintain blood glucose. One is glycogenolysis. The other one is gluconeogenesis. Do you all understand this? We have only 2 pathways in our body to increase the blood glucose. So what are the 2 pathways which can increase blood glucose? One is liver glycogenolysis. The other one is gluconeogenesis. So only when there is a defect of liver glycogenolysis or gluconeogenesis, there will be hypoglycemia. Whereas choice A, what is choice A? Branching enzyme defect. It's a defect of glycogen synthesis that is not going to cause hypoglycemia. Do you understand this? So Anderson or branching enzyme defect will not present with hypoglycemia. Again, glycogen synthase, the name by itself tells you that's an enzyme of which pathway? Glycogen synthase is an enzyme of which pathway? Glycogen synthesis. Again, will it cause hypoglycemia? No, because it's not an enzyme. Because it's not an enzyme related to glycogenolysis or gluconeogenesis, both these will not present as hypoglycemia. Now, how about choice C or acid maltase defect? Acid maltase defect is called as Pompey's. And what is that you need to know about Pompey's? Yeah, anybody? What is that you need to know about Pompey's? When acid maltase is defective, listen to this, when acid maltase is defective, only 2% of glycogen that is stored in muscle, only 2% of glycogen that is stored in muscle gets metabolized by acid maltase. So when that enzyme is defective, it causes, it affects the muscle. So both skeletal muscle and cardiac muscle will get affected. When cardiac muscle gets affected, it will present as cardiomegaly. When cardiac muscle fiber gets affected, it will present as cardiomegaly and cardiomyopathy. When skeletal muscle gets affected, it will present as hypotonia. What will it present as? It will present as hypotonia. So one of the causes of floppy baby, one of the cause of floppy baby will be acid maltase defect or Pompey's disease. So do you still think it can be Pompey's or acid maltase defect? When will you suspect acid maltase defect? You will suspect acid maltase defect only when there is a word cardiomyopathy, cardiomegaly, hypotonia, respiratory difficulties. So if you see any of these terms, then you can suspect Pompey's. In this case, it's only hypoglycemia. So after excluding all these choices, what are you left with? You are left with glucose 6-phosphatase defect, which is von Gierke's. Okay, so tell me all about von Gierke's. I'm going to explain all other manifestations. I'm going to tell you why lactic acidosis, why ketosis, why xanthomas. Okay, so in von Gierke's, the enzyme that is defective is glucose 6-phosphatase. Then glucose 6-phosphatase is defective. Glucose 6-phosphate cannot be converted to glucose. So it definitely causes hypoglycemia. What will it present as? It will present as hypoglycemia. But additionally, when glucose 6-phosphate accumulates, it gets into glycolysis. If it cannot become glucose, no other go, glucose 6-phosphate gets into glycolysis. And what will you get as a product of glycolysis? You get pyruvate, right? As a product of glycolysis, get pyruvate. This pyruvate gets converted to acetyl-CoA. And this acetyl-CoA will be used for fatty acid and cholesterol synthesis. Didn't I tell you just now that acetyl-CoA is the building block of both fatty acid and cholesterol? So acetyl-CoA is used for both fatty acid and cholesterol synthesis. And fatty acid and cholesterol will be stored as triacylglycerol and cholesterol ester. So the child will not only present with hypoglycemia, the child will also present with hypertriglyceridemia and hypercholesterolemia. And this hypertriglyceridemia is the reason for doll-like faces. What do you mean by doll-like faces? It is chubby cheeks. Okay, what is the reason for chubby cheeks? Triglycerides accumulate in the cheek. Okay, and that is the reason for xanthoma in the buttocks. Okay, and not always acetyl-CoA can be used for fatty acid and cholesterol synthesis. So excess acetyl-CoA will accumulate and that forms ketone bodies. Excess acetyl-CoA, when it cannot get into fatty acid and cholesterol synthesis, that forms ketone bodies, and that is the reason for ketosis. Okay, and pyruvate does not only become acetyl-CoA, it can become lactate, and that is the reason for lactic acidosis. So have you explained all the manifestations here? Okay, so tell me, what are the manifestations of von Gierke's disease? Glucose 6 phosphatase defect of course will present with hypoglycemia, but that's not the only manifestation. Along with hypoglycemia, there is hypertriglyceridemia, hypercholesterolemia, there is ketosis, lactic acidosis. Yeah, ketosis, lactic acidosis. Because of hypertriglyceridemia, there are chubby cheeks. Because there is hypercholesterolemia, there is xanthoma. And because of this elevation of TGL and cholesterol, there will be renomegaly and hepatomegaly. So if you find all these features, then you can say it is von Gierke's disease. Okay. So I hope you have all understood it. Is it clear? If it's clear, can I see a thumbs up from you all, please? So this is the next question. Complex 4 is inhibited by rotenone malonate BAL cyanide. Thank you, Pandit. Thank you, Shakir. Thank you, Varsha. So can you answer this? Complex 4 is inhibited by, yes, cyanide. Okay. So common poisons like hydrogen sulfide, cyanide and carbon monoxide. Why does it not enter into citric acid cycle? Acetyl-CoA of course enters into citric acid cycle, Pragya, even in von Gierke's. Okay, even in von Gierke's it gets into citric acid cycle. But when it gets into citric acid cycle, there's going to be no defect. That is why I didn't tell you about it. So, but not all acetyl-CoA can get into citric acid cycle. Citric acid cycle has got its own limitation. So when acetyl-CoA cannot get into citric acid cycle, that is when it becomes ketone bodies. That is when it gets into fatty acid and cholesterol synthesis. Do you understand that? Okay. So hydrogen sulfide, all common poisons like hydrogen sulfide, cyanide and carbon monoxide. Okay. Hydrogen sulfide, cyanide and carbon monoxide, all these inhibit complex 4. Okay. So now I will tell you about all these inhibitors and at what level they act. Okay. Because it's a revision session. We have to revise every fact related to the question that has been recently asked. Okay. So first I will tell you the direction of transport of electron, and then I will tell you where inhibitors act. So electrons get into electron transport chain through complex 1. From complex 1 it gets into Q. So these are the complexes of electron transport chain. We have complex 1 or NADH linked dehydrogenase. Complex 2 is succinate dehydrogenase. Complex 3, tell me what is complex 3? Complex 3 is cytochrome B and C1. Yeah, complex 3 is cytochrome B and C1. Complex 4 is cytochrome A and A3. Complex 4 is cytochrome A and A3. And complex 5 is ATP synthase complex. Is that clear? So these are the 5 stationary complexes. So what are the 5 stationary complexes? Complex 1 or NADH linked dehydrogenase. Complex 2 or succinate dehydrogenase. Complex 3 is cytochrome B and C1. Complex 4 is cytochrome A and A3. Complex 5 is ATP synthase complex. And what are the mobile complexes? Mobile complexes are ubiquinone or Q. Yeah, ubiquinone or Q placed between 1 and 3. And cytochrome C placed between 3 and 4. Yeah, so what are the two mobile complexes? Ubiquinone or Q placed between 1 and 3 and cytochrome C placed between 3 and 4. And if you're asking me why do we need such mobile complexes? Because these mobile complexes will move from one complex to another. They collect electrons from one complex and they deposit electron in the next complex. Okay. Now what is the direction of transport of electron? From NADH, electrons get into electron transport chain through complex 1. From complex 1, electrons go to Q. Can you see that here? From 1, it goes to Q. From Q, it goes to 3. From 3, it goes to C. From C to 4. From 4, the final acceptor of electron is oxygen. Yeah, from 4, the final acceptor of electron is oxygen. This is NADH. If it is FADH2, electrons enter into electron transport chain either through complex 2 or directly they get into Q. So from 2 electrons go to Q, which is non-protein. What does that mean? Are you asking me which is non-heme? All these are proteins. All these are cytochrome heme proteins. My friend, do you understand that? All these are cytochromal heme proteins. I don't know what you are asking. Maybe you saw a question wherein it was asked us which complex has got copper. So all these complexes have iron in the center. The only one complex which has got copper is complex 4 or cytochrome A and A3. Does that answer your question? Okay, so this is the direction of transport of electron. Now about inhibitors. Electron transport between complex 1 and Q here, yeah, electron transport between 1 and Q is inhibited by everything that starts with A. Amobarbitone, yeah, what is it? It is amobarbitone. 7:30. Yeah, why? Which is the non-protein complex in electron transport chain, it was asked. Non-protein complex. All these are cytochrome heme proteins. All these are, probably they asked you about ubiquinone. Yeah, ubiquinone is a derivative of cholesterol. Yeah, or byproduct of cholesterol synthesis. Was there ubiquinone among choices, my friend? Ubiquinone is a byproduct of cholesterol synthesis. It's a steroid. That is not a protein. Okay, that is probably the right answer. So electron transport between 1 and Q is inhibited by everything in A's. Amobarbitone starts with A. Pyrisidin A. Very good, Usha. Pyrisidin A ends with A. And then rotenone. Yeah, rotenone, it sounds like vitamin A, right? It is not vitamin A, but it sounds like vitamin A. Okay, so these are the 3 inhibitors which inhibit electron transport between 1 and Q. So can you answer this? Between 1 and Q, what are the inhibitors? 1 and Q, everything in A. The first one is amobarbitone. Second one is pyrisidin A. And the third one is rotenone. Okay. Now, complex 2 or succinate dehydrogenase is inhibited by malonate. Yeah, complex 2 or succinate dehydrogenase is inhibited by malonate. And then complex 3 to C, electron transport between complex 3 and C is inhibited by BAL and antimycin. Okay, BAL and antimycin. So, how do we remember it? Yeah, how do we remember it? 3. BAL has got 3 letters, right? So between 3 and C is inhibited by BAL and antimycin. And then electron transport between complex 4 and oxygen. Yeah, this is being frequently asked. Between 4 and oxygen is inhibited by hydrogen sulfide, cyanide and carbon monoxide. So what is the basic principle behind carbon monoxide poisoning? Are you worried about carbon monoxide poisoning because it inhibits electron transport between 4 and oxygen? No. We are worried about carbon monoxide poisoning because carbon monoxide has got very high affinity for Fe2 plus of hemoglobin. Yeah, carbon monoxide has got very high affinity to Fe2 plus of hemoglobin when compared to the affinity of Fe2 plus for oxygen. So carbon monoxide displaces oxygen away. That is the major principle of carbon monoxide poisoning. But apart from that, carbon monoxide also inhibits electron transport between 4 and oxygen. So are you clear about this? So these are the inhibitors that you will have to learn about. So what is the answer? Complex 4 is inhibited by, it is cyanide. Yeah, answer is cyanide. All the following are properties of genetic code except. Can anybody tell me the right answer? All the following are properties of genetic code except degeneracy, ambiguous, not punctuated, non-overlapping. What do you think is the right answer? Very good, Usha. Usha is rocking. Yes, your genetic code is unambiguous. Yeah, your genetic code is unambiguous. It is degenerate. It is not punctuated. It's non-overlapping. So what are the properties of genetic code? The first property of genetic code is it is degenerate. To understand why we call it as a degenerate genetic code, please answer few questions. Can you tell me totally how many codons do we have? Totally number of codons that we have. We have totally 64 codons. Out of these 64 codons, how many are stop codons? We have 3 stop codons. So totally how many codons code for amino acids? There are totally 64 codons, 3 are stop codons. So 61 codons code for amino acids. 61 codons code for how many amino acids? They code for just 20 amino acids. So what do you find here? There are 61 codons which code for just 20 amino acids, which means more than one codon. Yeah, this means more than one codon can code for a single amino acid. That is called as degeneracy. For example, GGG, GGC, GGA, all these code for glycine. Yeah, all these code for glycine. So what is the state here? More than one codon can code for a single amino acid. That is called as degeneracy. There is an exception to this rule. There are 2 exceptions to this rule. One is methionine, the other one is tryptophan. So methionine and tryptophan, they are coded by only one codon each. Do you understand this? Methionine and tryptophan do not follow degeneracy. They are coded by only one codon each. So though your genetic code is degenerate, it is unambiguous. What do you mean by unambiguous genetic code? What did I tell you? I said more than one codon can code for a single amino acid. But do you think the reverse is true? Do you think the reverse is true? Can I ever say I will have one codon coding for more than one amino acid? Can I ever say I will use one codon to code for more than one amino acid? I cannot say that. In that case, I don't need a code at all. Do you understand this? In that case, I don't need a code at all. And that is why though our genetic code is degenerate, it is unambiguous in the sense not more than one amino acid. Not more than one amino acid can be coded by a single codon. Okay, so it is unambiguous. And then it is non-overlapping and it is not punctuated. What do I mean by not punctuated genetic code? Do you have a punctuation after every 3 nucleotides like this? Do you have a punctuation after every 3 nucleotides like this? No, right? Had it been punctuated like this, tell me what would have happened if there is a loss of say 1 nucleotide here. Had it been punctuated like this, and if there is a loss of 1 nucleotide anywhere in between, then the amino acid that is coded by this codon alone should have been defective. But we know that is not what happens. When there is a loss of 1 nucleotide here, then 4th and the 6th will be read along with 7th. 8th and 9th will be read along with 10th. Yes, 11th and 12th will be read along with 13th. So the entire frame of reading gets shifted from that place, right? The entire frame of reading gets shifted from that place just because frame shift mutation is possible. Do you understand this? Just because frame shift mutation is possible, we know for sure our genetic code is not punctuated. And it is non-overlapping. What do you mean by non-overlapping genetic code? Will you ever say I will use first, second and third nucleotides as my first codon, but I am going to use third, fourth and fifth as my second codon? Yeah, I will use 4, 5 and 6 as my third codon. Will you allow one codon to overlap with another? Will you allow one codon to overlap with another? No. So we know our genetic code is non-overlapping. And last property is our genetic code is universal with few exceptions. What do you mean by universality? Do you have a unique genetic code for every cell? Will you ever say I'm going to use GGG to code for glycine only in hepatocyte, but I'm going to use the same GGG for tryptophan in my B cell? Do you say that? Do you say that? We don't say that. So our genetic code is universal. Every cell, it's the same genetic code, but with few exceptions. What are the exceptions? Mitochondrial DNA. So what is the exception as far as mitochondrial DNA is concerned? Usually what is UGA, all of you? Usually what is UGA? It is a stop codon, right? UGA is a stop codon. But in mitochondria, it codes for tryptophan. UGA codes for tryptophan in mitochondria. Usually AGA and AGG code for arginine. Usually in your nuclear DNA, AG and AGG code for arginine, but both act as stop codons in mitochondria. Okay, so that is why it is universal but with few exceptions. So can you tell me all about properties of genetic code? Can you all please answer this? What are the properties of genetic code? Our genetic code is degenerate. What are the two exceptions? Methionine and tryptophan are coded by only one codon each. So it is degenerate. Exceptions are methionine and tryptophan. It is unambiguous. It is non-overlapping. It is not punctuated. It is universal with few exceptions. Okay, what is the exception I told you? In mitochondrial DNA, UGA is not a stop codon but it codes for tryptophan. Usually AG and AGG code for arginine, but in mitochondria they act as stop codons. Okay. Answer this please. The optically inactive amino acid is. Which is the optically inactive amino acid? Very good. Good Pragya. Yes, glycine. Okay, so I'm going to use this MCQ to discuss few facts, few other facts that can be asked as far as amino acids are concerned. Okay, so first about glycine. Glycine is the simplest amino acid because in glycine the R group is just a H. The side chain in glycine is just a H. And so it does not have any asymmetric carbon atom. So which amino acid does not have an asymmetric carbon atom? It is glycine. And anything which does not have an asymmetric carbon atom cannot exhibit stereoisomerism. Okay, and anything which cannot exhibit stereoisomerism will be optically inactive. So which is the optically inactive amino acid? It is glycine. Which amino acid cannot exhibit stereoisomerism? It is glycine. Okay, and glycine disrupts alpha helix. So there are two amino acids which disrupt alpha helix. One is glycine, the other one is proline. Okay, glycine and proline disrupt alpha helix. So now few other facts about other amino acids. Let me start with aromatic amino acids. So what are the aromatic amino acids? Tell me answer please. What are the three aromatic? Very good Usha, very good Hemant. Tell me what are the three aromatic amino acids? Phenylalanine, tyrosine, tryptophan. Yeah, phenylalanine, tyrosine, tryptophan. And all these three aromatic amino acids absorb UV light at 280 nanometer. What do? They absorb UV light at 280 nanometer. Please memorize it. Okay. Purines and pyrimidines absorb UV light at 260 nanometer. Your adenine, guanine, cytosine, thymine, they all absorb light at 260 nanometer, whereas aromatic amino acids absorb light at 280 nanometer. Okay. Now, what is the ring that is present in phenylalanine? Phenylalanine has got a benzene ring, whereas tyrosine has got a phenol ring. Okay, tyrosine has got a phenol ring. And tryptophan has got an indole ring. Okay, benzene ring in phenylalanine, tyrosine ring in, tyrosine has got a phenol ring and tryptophan has got an indole ring. Okay, and then what are the amino acids which I told you disrupt alpha helix? Before that, tell me what are the hydroxyl group containing amino acids? Yeah, what are the hydroxyl group containing amino acids? Serine, threonine and tyrosine. There are 3 hydroxyl group containing amino acids, serine, threonine and tyrosine. What are the sulfur containing amino acids? All of you answer this. What are the sulfur containing amino acids? Cysteine and methionine. Okay, cysteine and methionine are the 2 sulfur containing amino acids. And then the 2 amino acids which disrupt alpha helix will be proline and glycine. Okay, 2 amino acids which disrupt alpha helix will be proline and glycine. And the last fact is the amino acid which can act as a physiological buffer. The amino acid which can act as a physiological buffer is histidine. Okay, it is histidine. So have you memorized all these facts? These are simple one-liners. These are simple one-liners that can be asked you straight away. Okay. So what is answer? The amino acid which acts as a physiological buffer is histidine. And for histidine, I want you to have a mnemonic. The mnemonic is HIP. Yeah, what does HIP stand for? H stands for histidine. I stands for imidazole group. Yeah, H stands for histidine. I stands for imidazole ring. And P stands for Pauli's test. Okay, so histidine, imidazole ring and Pauli's test. And another mnemonic as far as amino acids are concerned is very good, my friend. Good. So it is TIA. What does TIA stand for? T stands for tryptophan. Tryptophan has got an indole ring. Yeah, tryptophan has got an indole ring and it answers aldehyde test. Okay, so histidine answers Pauli's test. Tryptophan answers aldehyde test. So HIP and TIA, transient ischemic attack. Tryptophan is indole ring and aldehyde test. Okay. A 40-year-old man presents with sclera of eyes and pinna having black pigmentation. The color of the urine turns dark on standing. What is the probable cause? So tell me the right answer. Urine turns dark on standing. So it is black urine disease. Very good, Varsha. Very good, my friend. Very good, Shakir. Very good. Varsha is answering more about the condition. Yes, Nisha. So it is black urine disease. What is black urine disease? It is alkaptonuria. So let me tell you few facts about alkaptonuria. The enzyme which is defective in alkaptonuria is homogentisate oxidase. And this is an enzyme that is involved in tyrosine metabolism. Homogentisate oxidase is an enzyme that is involved in tyrosine metabolism. When this enzyme is defective, homogentisic acid accumulates. And this homogentisic acid gets converted to benzoquinone acetate. Yeah, homogentisic acid which accumulates gets converted to benzoquinone acetate, which undergoes polymerization to form melanin. And this melanin is the reason for pigmentation. Do you all understand this? So where will you see pigmentation? Pigmentation is seen in urine. That is why urine turns dark on standing. And this pigment also accumulates in cartilage, wherein there is cartilage destruction. And this cartilage destruction is the reason for eucranosis. What do you mean by eucranosis? The patient will often complain of multiple intervertebral disc bulges and prolapses. Yeah, the patient often, alkaptonuria is not a life-threatening condition. Please understand this. It's not a life-threatening condition. The patient only presents with what? The patient presents with multiple intervertebral disc bulges or prolapses, multiple joints involvement. And on observation, you'll find pigmentation of pinna, tip of the nose, thenar and hypothenar eminences. And if you observe, you will also see pigmentation of mucous membrane. Yeah, pigmentation of sclera, that is called as Osler's sign. Can you see that here? Pigmentation of sclera both along the line of attachment of medial rectus and lateral rectus. What is this called as? This is called as Osler's sign. And this is the first sign of alkaptonuria. Okay. And as one of you have mentioned it, my friend has answered it. Yes, it is a reducing substance. Homogentisic acid is a reducing substance. So urine will answer Benedict's test. Okay, urine will answer Benedict stress. So all these are features of alkaptonuria. So what are the facts I've told you about alkaptonuria? Can you all answer? Alkaptonuria is caused by a defect of homogentisate oxidase. Homogentisic acid is converted to benzoquinone acetate. That becomes melanin. And this melanin is the reason for ochronosis and pigmentation of skin and mucous membrane. Pigmentation of mucous membrane is called as Osler's sign, and urine turns dark on standing. Benedict stress will be positive. Okay. Now tell me about phenylketonuria. Let's revise all the other conditions also here. Tell me about phenylketonuria. It is caused by the defect of which enzyme? Phenylketonuria is caused by a defect of phenylalanine hydroxylase. When that enzyme is defective, you classically observe a mousy odor. So if the history says mousy odor, immediately say it is phenylketonuria. How do we remember it? Just remember, mouse and keyboard go hand in hand. Yes or no? Yeah, mouse and keyboard go hand in hand. So mousy odor, key. What is key? Yeah, mousy odor, key is phenylketonuria. And they also present with hypopigmentation. Why hypopigmentation? The function of phenylalanine hydroxylase is to convert phenylalanine to tyrosine. So when this enzyme is defective, there is no tyrosine. Without tyrosine, melanin cannot be synthesized. So the child will show hypopigmentation, white hair. You will see white hair, and then cornea will not be pigmented adequately. So hypopigmentation is a feature, and mental retardation. Yeah, mental retardation is also a feature of phenylketonuria. So are you clear about this? So if you see the history, yeah, the history says mousy odor, hypopigmentation, mental retardation. Then what will be your answer? Phenylketonuria caused by a defect of phenylalanine hydroxylase. Now what is maple syrup urine disease? Maple syrup urine disease is caused by the defect of which enzyme? Branch chain keto acid dehydrogenase enzyme. Yeah, maple syrup, very good my friend, very good Varsha. Maple syrup urine disease, it is characterized by, as the name indicates, characterized by burnt sugar odor of urine. And additionally, it is caused by a defect of branch chain keto acid dehydrogenase enzyme. And this condition responds to, thiamine administration. Because branch chain keto acid dehydrogenase enzyme is dependent on thiamine, this condition responds to thiamine administration. Okay. Hartnupp's disease. Tell me what is Hartnupp's disease, all of you? Hartnupp's disease is malabsorption syndrome. What malabsorption? Tryptophan malabsorption. Very good, my friend. So Hartnupp's disease is nothing but tryptophan malabsorption. When tryptophan is not getting absorbed, niacin cannot be synthesized, because 60 milligram of tryptophan is equivalent to 1 milligram of niacin. So when there is niacin deficiency, you will find 3 Ds of pellagra. So what are the 3 Ds of pellagra? Diarrhea, dermatitis and dementia. Okay, and this is a favorite image of FMGE. They often give you this image. They ask you to make a diagnosis. So what you see here is Castle's necklace. Photosensitive dermatitis. Those parts of the body which are exposed to sunlight, that is dermatitis. So what is it? The dogs are fine, my friend. So what is it? Castle's necklace. So Castle's necklace is dermatitis part of pellagra. Okay. Diarrhea, dermatitis and dementia. So what is the right answer here? Urine turns dark on standing, which means it is alkaptonuria. I think we can end the session now. So just tell me what is answer. A 4-month-old infant presents with complaints of refusal to suck breast milk, hypoglycemia, ketosis and burnt sugar odor. So what is burnt sugar odor? Maple syrup urine disease. And just now I told you maple syrup urine disease is caused by the defect of branch chain keto acid dehydrogenase. Okay. And isovalerial CoA dehydrogenase, for completion's sake. Answer here is choice C. But for completion's sake, isovalerial CoA dehydrogenase deficiency is called as isovaleric acidemia. I read it as, ma'am, please go. Okay. So it is called as isovaleric acidemia, and it is characterized by sweaty feet odor. Burnt sugar odor is maple syrup urine disease. Isovaleric acidemia is sweaty feet odor. Okay. So these are the facts that I wanted to tell you. Okay. So get the PDF, download and revise. And this, I think I've covered many topics in FMGE. So based on this, you can recollect many other facts and concepts. Okay. So all the best. Thank you. See you all soon. Approximately, I can't assure you on that, Varsha, but I'm assuming that most of the questions will be based on inborn errors of metabolism, and most will be based on what we have discussed. But try to watch the FMGE Rapid Revision session, special classes that I've taken. Yeah, so in which case you will be able to cover most of the questions.